Good morning. We're ready to start Unit 6 for the Sleep Medicine and Respiratory Care lectures, and this week we'll be covering monitoring respirations. The next 3 slides will list the objectives for monitoring respirations, and they include explain the equipment needed and the techniques to measure airflow during sleep studies, explain the significance and the technique for measure of respiratory effort and SaO2, explain the significance of measuring pulse oximetry in sleep studies and its need in sleep monitoring, explain the significance of CO2 monitoring and the various techniques to monitor CO2 during sleep studies, and explain the equipment used and the significance of recording storing during sleep studies. Outline the rules and techniques of scoring adult respiratory events, identify the recommended respiratory sensors used during sleep study in adults, outline the rules and techniques for scoring respiratory events in children. The first objective we're going to work on is explain the equipment needed and the techniques to measure airflow during sleep studies. Here on this slide, I've made a list of different pieces of equipment that we can use to measure airflow. We're going to cover each one in a little bit of depth. We don't use all of these during a sleep test, but we can use what's recommended by the AASM. The first ones we're going to talk about are the thermocouple and thermistor. The thermocouple, well, both sensors are used to measure temperature. The tracings look identical. They detect airflow at the nostrils and the mouth, and it detects the rate of temperature change between expired air, warmed by the body, and room air, cooled by the environment. Thermocouple responds to the temperature change. It measures the difference between two dissimilar metals, the difference in electrical charge between 2 points in a circuit expressed in volts, and utilizes 3 wires, one in front of the mouth, one in front of each nair. The thermistor requires the use of a battery. Both thermistor and thermocouple requires disinfecting between patients. Now we're going to talk about pneumotachometers and pneumotachographs. These are incorporated into some CPAP units. It's a device that measures the flow of respiratory gases. It's not very accurate, and masks should cover the whole mouth and nose to be effective, a full face mask. It's used when a quantitation or an exact measurement of airflow and volume are needed. Nose and mouth must be fully covered with no leaks and large for the patient to accommodate. It's difficult for the patient to accommodate and maintain in place, and it can be calibrated at different airflows. When troubleshooting, accuracy is affected by warm room, ceiling fan, moisture may collect in the sensors affecting the data. Respiratory inductive plethysmograph, or RIP, is considered the gold standard for use in sleep testing. There's types of belts that are put around. The elastic belt stretches around the body, and the disposable belts can be cut to the length needed to fit around the circumference of the patient. The RIP uses a piezoelectric sensor. Calibration is required before the beginning of the test and at the end of the test. Contains a device with zigzagging coiled wires sewn into the belt that react to inhalation and exhalation. The zigzagging wires run the entire length of the belt. One belt goes around the upper abdomen, just above the belly button, and one around the chest, mid-chest. Belt can become loose or overlap, causing an ineffective signal, or belts that are too tight may be uncomfortable for the patient. Another type of measurement is the pneumograph. Electrodes are placed on the opposite sides of the part of the body, usually on the abdomen. Changes in electrical impulses between two are recorded. Skin impedance at times can give false readings and primarily used on infants. Next, we have piezo belts. This belt contains a piezo crystal device that is located on a very small portion of the belt. It's ineffective if the patient were to lie on the sensor, and it's ineffective if the belt becomes loose. Another device is called a mercury strain gauge. It contains a tube with mercury and measures inhalation and exhalation. Another device is called the intercostal EMG. It's least expensive, it's rarely used with PSGs, and it's likely to contain EKG artifact. Next we have on our list is esophageal pressure gauge. It's invasive. It's an esophageal manometer, can be esophageal catheter, esophageal balloons, or water-filled catheters. They're rarely used in PSG and very uncomfortable for patients. They're very accurate in measuring interthoracic breathing effort and measures upper airway resistance. Cardiopneumographs measures heart rate and respiration in one channel. A battery is required. Pulse oximetry is next on the list, and it's most appropriate in non-invasive technique for continuous monitoring of the oxygen saturation and the pulse. It's an extremely important part of the sleep study. Probes are attached to the finger, and transmit light pulses through the capillary beds. Earlobe or toe may be used if finger is not accessible. SpO2 results of pulse oximeter are accurate in patients with good perfusion and saturation of 70% or higher. Pulse oximetry is recommended for monitoring in the polysomnography. A normal SpO2 on room air at 21% of oxygen is 95 to 97%. Accuracy is affected by perfusion. Shock and hypotension can affect it. SpO2 decreases with respiratory events. Low oxygen alarms on the unit should be used. Alarm may be disabled only if the technologist is in constant attendance. And pulse oximetry may also be recorded on a strip chart. In troubleshooting the pulse oximetry, motion artifact is the most common problem. Dark skin pigmentation can also cause errors. Nail polish, you must remove all nail polish before applying the attaching. Ambient light, you can cover the sensor with a towel or cloth. If there's a sudden fall in readings without a change in the patient's condition, then there is a possible malfunction of the probe. The probe may need to be changed or reattached. In patients with poor peripheral perfusion, the oximetry pulse rate should be compared to the ECG cardiac rate. Overnight pulse oximetry or home oximetry, the indications it's used as a screening tool for identifying patients with sleep-related breathing disorders. It's portable and easy to wear. Next we have nasal pressure transducer. It detects fluctuations in pressure from inspiration and expiration. It measures airflow through a nasal cannula. The cannula is connected to a pressure transducer. It's very accurate in detecting hypopneas and respiratory effort-related arousals. Best used with a DC application system, has a constant voltage output, and may be used inline or under the mask with CPAP. Problems can occur with the nasal pressure transducer. They include poor positioning of the prongs, the nasal prongs, the loss of signal from the nasal secretions. Patient may breathe orally. If used with AC amplifier, low filter settings may cause irregular or dampening waveform. The next piece of equipment, monitoring equipment for respiratory, is capnograph or end-tidal CO2 monitoring. It's a graphic display of CO2 levels as they change breath by breath. Measures, exhaled carbon dioxide content by using an infrared absorption. May be correlated with an arterial blood gas, and it can be nasal oral cannula used to detect exhaled CO2. A normal end-tidal CO2 will be lower than arterial PCO2. Normal ABG PCO2 equals 40 torr, where exhaled CO2 is 30 torr. The end-tidal CO2 can also be displayed as a percent. A normal value is 3 to 5%. There are conditions that can affect the end-tidal CO2, and it could be ventilation perfusion ratio of the lungs, COPD when the CPAP or bilevel is applied, Sleep may alter the difference between PaCO2 and P end-tidal CO2. Obesity, hypoventilations, cannot classify your apneas or hypopneas, and used in detecting hypoventilation, hyperventilation. Next, we have the transcutaneous PO2 and PCO2 monitor. This is an adaptation of the Clark and Severnhouse electrodes that allows continuous, non-invasive PO2 and PCO2 measurement by electrodes placed on the skin instead of a single measurement with a blood sample. Commonly used in neonatal and pediatric sleep studies. Heating the skin around the electrode to 43 to 45 degrees centigrade improves the capillary blood flow or perfusion and enhances gas movement through the skin. And then we can measure it. Accuracy decreases with increased skin thickness, anemia, condition of decreased perfusion such as shocks, burns, or vascular disease or cardiac diseases. The electrode is best placed over flat areas with good perfusion, normally on the chest, just beneath the center of the right or left clavicle. The electrode site should be changed every 4 hours. If redness or blistering of the skin occurs, the electrode is moved to a new site more often. Calibration is done on room air with a zeroing solution. If unable to calibrate, check for torn membrane or poor connections. Air leaks will increase the TCPO2 to a higher than arterial PO2. Okay, the last one on our list is the snore microphone or sensors or laryngeal microphones. These are applied using medical tape and record vibration to send to the amplifier. We avoid placing it over the carotid artery and is placed over the throat. We're going to move on to objective 2, which is explain the significance and the technique for measurement of respiratory effort in SaO2. First, we're going to tackle respiratory effort, the significance of it. Respiratory effort is the placement of respiratory bands. We place the bands under the left armpit with the lead wire facing upwards. Adjust the black extender belt so the belt is secure but not tight. We put the abdominal band around the umbilicus above the belly button, or if not, this position is not possible, below the lower edge of the left rib area. Troubleshooting incorrect application of respiratory bands can cause poor signals and do not restrict the patient's comfort or breathing. What's the significance of this? Well, we want to see them breathe in and out. We want to see inspiration, expiration, chest wall movement. Next, we attach the nasal cannula. It's a clear tubing which is positioned directly in the flow of air just under the thermistor. Secure in place. The thermistor will be placed on top of the nasal the cannula. Attach the thermistor, the temperature-sensitive wires. They're positioned over the flow of air. The nasal beads of the thermistor should not be within the nares, and then secure. The thermistor is sensitive to displacement or to moisture. Let's talk a little bit about SaO2 monitoring, SpO2 monitoring. To attach the oximeter, you attach the oximeter to the finger. It records the pulse and oxygen saturation using a small light that shines through the finger. Oximetry should be placed on the ring finger of the non-dominant hand. If large rings are worn, it may use the middle or index fingers. Colored nail polish defeats the function of the oximeter. It must be removed from the finger prior to the sensor attachment. Place the finger into the sensor nail side up with the tip of the center line mark on the curved area. You wrap the tape firmly around the finger. The fingernail should not be covered with tape during this step. Do not stretch the tape. May cause inaccurate readings or skin blister. Be sure that the emitting and receiving diodes directly face each other. After securing the oximeter, ask the patient if there's any throbbing felt. Loosen the tape if the finger is throbbing. Use a circular stress loop with the cable in the tape and check that the participant can bend his hand in all directions. If not, reapply with more slack in the cable. Okay, we're going to move on to objective 3 of today's lecture. We're going to explain the significance of measuring pulse oximetry in sleep studies and its need in sleep monitoring. What is the significance of measuring pulse oximetry? Well, one of the most important measurements in a person's oxygen level during the different stages of sleep. Desaturation is when the level falls below what the body needs to function normally, and it tells the doctor how severe obstructive sleep apnea is, but it is also an indication of future health concerns. So when the muscles relax and block your airway during sleep, breathing can stop for anywhere from 10 seconds to over a minute in some cases. A person may be completely unaware of these gaps. The bed partner will often notice and become alarmed. And during these breathing gaps, people receive less air, which causes their blood oxygen level to drop. Generally, they return to normal once regular breathing starts again. Frequent breathing gaps can pose serious health concerns. Measuring pulse oximetry during sleep can help detect these breathing gaps. If you are getting enough oxygen during the day, your oxygen level will be between 95 and 100%. But during sleep, respiratory rates slow, so 90% is considered normal. With obstructive sleep apnea, repeated gaps in breathing cause blood oxygen level to drop by 3% or more, leading to an oxygen desaturation. Below 90% oxygen levels are considered abnormal, severely abnormal when below 80%. Severity of OSA is measured based on blood oxygen levels, but also how frequently and how long breathing stops and how much airflow is reduced. Breathing gaps of longer than 10 seconds with airflow reduction of 30% are problematic. Okay, we're going to go on to the next objective, explain the significance of CO2 monitoring and the various techniques to monitor CO2 during sleep studies. Monitoring carbon dioxide, CO2, is of crucial importance during sleep disordered breathing in order to assess the consequences of respiratory events on gas exchange. CO2 recording is necessary for diagnosis of alveolar hypoventilation and can be performed by means of end-tidal CO2 or transcutaneous CO2. However, the monitoring of CO2 is not usually performed on a routine basis due to a lack of simple, cheap, and reliable CO2 monitors. A carbon dioxide blood test measures the amount of carbon dioxide in your blood. Carbon dioxide is an odorless, colorless gas. It is the waste product of your body that your body makes when it uses food for energy. Excuse me. The blood carries carbon dioxide to your lungs. When you exhale, you breathe out the carbon dioxide. Having too much or too little of carbon dioxide in your blood can be a sign of a health problem. Other names and other methods are carbon dioxide content, CO2 content, carbon dioxide blood test, bicarbonate blood test, bicarbonate test, total CO2, TCO2, carbon dioxide content, CO2 content, bicarb, and so these are different ways that you can measure content of CO2 in the blood. So why do we want to monitor carbon dioxide during sleep studies? Well, monitoring of carbon dioxide is employed in the identification of various hypoventilation syndromes during sleep. Hypoventilation is defined as the level of ventilation that is lower than that necessary to meet the metabolic demands of the body. Hypoventilation results in the increase of CO2 level in the blood. Increases in CO2 result in arousals from sleep to breathe more deeply so it as to help expel the CO2. Increased CO2 during wakefulness is typically associated with increased sleepiness and fatigue. CO2 monitoring is employed in overnight studies of children to detect prolonged intervals of obstructive hypoventilation. These are mild obstructive events accompanied by abnormal increases in CO2. Not generally seen in adults, as well as in conditions afflicting children and adults with nocturnal hypoventilation is suspected. In the muscle weakness associated with ALS, polio, MD, or in various lung diseases such as COPD, asthma, and cystic fibrosis. In morbid obesity and restrictive thoracic disorders such as kyphosis. Way of measuring and that shows a graphic display of CO2 levels as they change is with the capnograph or end-tidal CO2. It measures the exhaled carbon dioxide using an infrared absorption. It may be correlated with an arterial blood gas. Nasal oral cannula is used to detect the exhaled CO2. Another form of measuring CO2 is with the transcutaneous CO2 monitor. It provides a non-invasive measurement of gas tension as to measure arterialized capillary blood gas by enhancing diffusion across the skin. There's a disadvantage to using the TCO2 monitors is that the sensor tends to burn the skin after prolonged usage. To ensure the skin and sensor maintain a constant temperature, the sensor is heated to about 42 degrees Celsius and must be repositioned during the night to prevent burning, and this can cause sleep disturbances to occur when we change the position. It's used in pediatric sleep studies and can only be an estimate of PCO2. Is a qualitative rather than a quantitative measure, and accuracy decreases at higher PCO2 levels. So why do we want to take or monitor CO2? The retention of carbon dioxide in the blood is an important consequence of a handful of sleep disorders that affect breathing, especially sleep apnea, central hypoventilation syndrome, and obesity hypoventilation syndrome. Carbon dioxide retention is called hypercapnia. Many people have no symptoms of hypercapnia, but if they do, they're likely to feel drowsy or find it hard to think straight. Severe hypercapnia, on the other hand, can cause noticeable symptoms such as increased heart rate, blood pressure, or muscle twitches. It can lead to respiratory failure if untreated. We covered this in a previous slide. The normal end-tidal CO2 will be lower than arterial PCO2, so it's important to correlate the two. The PaCO2 is usually about 40 torr for normal. End-tidal CO2 is 30. End-tidal CO2 can also be displayed as a percent. Normal value is 3 to 5%. Conditions affecting the ventilation perfusion ratio of lungs can alter the end-tidal CO2. These include COPD, when CPAP or bilevels is applied. Sleep may alter the differences between PaCO2 and end-tidal CO2. Obesity, hypoventilation. You cannot classify the apneas or hypopneas, and useful in detecting hypoventilation and hyperventilation. Transcutaneous PO2 and PCO2 monitoring is also another method of monitoring. It's an adaptation of the Clark and Severnous electrodes that allows continuous non-invasive PO2 and PCO2 measurement by electrode placement on the skin instead of a single measurement by a blood sample. It's commonly used in neonatal and pediatric sleep studies. Heating the skin around 43 to 45 degrees centigrade improves the capillary blood flow perfusion and enhances gas movement through the skin. Accuracy decreases with skin thickness, anemia, conditions of decreased perfusion such as shocks, burns, vascular disease, or cardiac abnormalities. Placement of the electrode is best over flat areas for good perfusion. It's normally on the chest, just beneath the center of the right or left clavicle. The electrode site should be changed every 4 hours if redness or blistering occurs, and the electrodes move to a new site more often. Calibration is done on room air with zeroing solution. If unable to calibrate, check for torn membrane or poor connections. Air leaks will increase the transcutaneous PO2 to read higher than the arterial PO2. Okay, we're moving on to objective number 5, explain the equipment used and the significance of recording snoring during sleep studies. Quantifying snoring is difficult, most centers settle for a qualitative measure, louder and softer rather than decibel level, provided by the microphone taped to the neck. Tech notes are good supplement to the recording, can monitor snoring using the intercom or even stand outside the room door, and can include assessment of the snoring in their notes. Okay, we're moving on to objective number 6, outline the rules and technique of scoring adult respiratory events. Updated rules for scoring respiratory events in sleep. The goals for this task force was to clarify and simplify the current scoring rules, to review evidence of new monitoring technologies relevant to the scoring rules, and to strive to greater coordinates between adult and pediatric rules. We're just going to talk about the respiratory event scoring rules in the next few slides. The general consideration was for the detection of apnea and hypopnea. The sensors for apnea detections include the oral nasal thermal sensors. There's an advantage of being able to detect both nasal and oral airflow at the same time, and this was recommended. Thermal sensors detect a change in temperature between inhaled and exhaled gas, included thermistors, thermocouples, or polyvinylidene sensors, and to broaden the definition of thermal sensors to include the PVDF sensor. Some of the other rules include alternative sensors for apnea detection, such as the nasal pressure transducer or the RIP in adults. In children, nasal pressure signal is not the summed RIP. Use of the COT waveform to detect apnea. The RIP sum, RIP thorax, and RIP abdomen are the sum thorax and abdominal signals for respiratory inductance, polysomnography. Plasmography. The presence of apnea is documented by the oral nasal thermoflow and capnography, and note that the capnography signal lags behind the flow signal, and the event depicted is obstructive apnea. Thoraabdominal paradox is noted during the event, but not during the unobstructed breathing. Scoring of apneas in adults is recommended. Score a respiratory event as an apnea when both the following criteria are met. A drop in the peak signal excursion by greater than or equal to 90% of pre-event baseline using an oral nasal thermal sensor, PAP device, or an alternative sensor, apnea sensor. And the duration of the greater than or equal to 90% drop in sensor signal greater than or equal to 10 seconds. Score an apnea as obstructive if it meets apnea criteria and is associated with continued or increased respiratory effort throughout the entire period of absence of airflow. Score an apnea as central if it meets apnea criteria and is associated with absent inspiratory effort throughout the entire period of the absence of airflow. And score an apnea as mixed if no airflow or effort followed by a period of no airflow with respiratory effort. Recommended scoring of hypopneas. Score a respiratory event as an hypopnea if all the following criteria are met. The peak signal excursion drop by greater than or equal to 30% of a pre-event baseline using nasal pressure, PAP device flow, or an alternative hypopnea sensor. The duration of greater than or equal to 30% drop in signal excursion is greater to or equal to 10 seconds. There is a greater than or equal to a 3% oxygen desaturation from pre-event, or the event is associated with an arousal, and there is a greater than or equal to 4% oxygen desaturation from a pre-event baseline. Scoring respiratory effort related arousals recommended is to score a respiratory event as a respiratory effort related arousal, RERA, if a sequence of breaths occurs lasts greater than or equal to 10 seconds, characterized by increasing respiratory efforts or by flattening of the inspiratory portion of the nasal pressure or PAP device flow waveform, leading to an arousal from sleep when the sequence of breaths does not meet the criteria for apnea or hypopnea. In scoring Cheyne-Stokes breathing, it's recommended that you score a respiratory event as Cheyne-Stokes breathing if both the following are met. Episodes of greater than 3 consecutive central apneas and/or central hypopneas separated by a crescendo and decrescendo change in breathing amplitude with a cycle length of greater than 40 seconds, or there are greater than 5 central apneas and/or central hypopneas per hour of sleep associated with crescendo and decrescendo breathing pattern recorded over greater than 2 hours of monitoring. Okay, we're moving on to objective number 7 on our this week of objectives for this lecture. I've listed here some different graphs indicating the different recommended sensors for sleep studies with adults. You'll note on this first graph that respiratory parameter is airflow used both by oral nasal thermal flow sensor and the nasal pressure transducer during a diagnostic study. The sensor can be a variety of sensors, including the oral nasal thermal airflow sensor to score apnea, a nasal pressure transducer to score hypopnea, a PAP device for flow signal to score apneas and hypopneas during CPAP titration, a respiratory effort belt, which may include one of the following: esophageal manometry, a dual thoraabdominal RIP belt, a dual thoraabdominal PVD belt. It's all acceptable in adults. And then, of course, oxygen saturation. I've included in this graph what is the level of recommendation. When it states recommended, this is recommended for the rules for routine scoring of respiratory events that should be followed. Acceptables, these are rules that may be used as alternatives to the recommended rules at the discretion of the clinician or investigator. Either the recommended or acceptable should be followed. Optional are rules that do not need to be followed but may be at the discretion of the clinician or investigator. In the respiratory sensor classification, recommended is the sensor that should be used for scoring a respiratory event. Alternatives are sensors that can be used for scoring a respiratory event if the recommended sensor is not functioning or the signal is not reliable. Here are the recommended sensors for scoring, to help scoring with a respiratory event in apnea. You select one of the following: a nasal pressure transducer, RIP sum, RIP flow, PVDF sum, which can be acceptable in adults only, entitled CO2, PCO2 accepted in children. For hypopnea, oral nasal thermal airflow sensor, RIP sum, RIP flow, dual thoraabdominal RIP belts, or PVD sum, which is acceptable in children, but not in adults, but not in children. Okay, we're at the last objective for this week, and that includes to outline the rules and technique of scoring respiratory events in children. First of all, let's define children. Ages for which the pediatric respiratory scoring rules apply include the criteria for respiratory events during sleep for infants and children can be used for children less than 18 years, but an individual sleep technologist can choose to score children greater than or equal to 13 years of age using the adult criteria. In order to have the ability to score hypopneas, apneas, or respiratory monitoring, we need to make sure that we use specific equipment. And here are some technical specifications that are recommended by the AASM. For identification of an apnea during a diagnostic study, use an oral nasal thermal airflow sensor to monitor airflow. For identification of hypopnea during a diagnostic study, use a nasal pressure transducer to monitor airflow. For identification of hypopnea during the study when nasal pressure transducer does not, or the signal is not good, use one of the following monitors to monitor airflow: oral nasal thermal airflow, RIP sum, RIP flow, or dual thoracic abdominal RIP belts. Okay, some more recommendations. During PAP titration, use the PAP device flow signal to identify the apneas or hypopneas. For monitoring respiratory effort, use one of the following: esophageal manometry, dual thoracic abdominal RIP belts. For monitoring oxygen saturation, use the pulse oximeter with a maximal acceptable signal averaging time of less than 3 seconds and a heart rate of 80 beats per minute. For monitoring snoring, use an acoustic sensor, a microphone, or a piezoelectric sensor, or a nasal pressure transducer. For detection of hypoventilation, use arterial PCO2, transcutaneous PCO2, or end-tidal PCO2. And for detection of hypoventilation during PAP titration, use arterial PCO2 or transcutaneous PCO2. Okay, some more information about measuring the event duration. Identification of an apnea does not require a minimum desaturation criteria in children. The entire event should be scored as an apnea if a portion of the respiratory event that would otherwise meet criteria for hypopnea meets the criteria for apnea, including a 2-breath minimum. If the apnea or hypopnea event begins or ends during an epoch that is scored as sleep, the corresponding respiratory event can be scored and included in the computations of the AHI. This usually occurs when an individual has a high AHI, with events occurring so frequently that sleep is severely disrupted, and epochs may end up being scored as wake, even though less than 15 seconds of sleep is present during this epoch containing the portion of the respiratory event. If apnea or hypopnea occurs entirely during an epoch scored awake, or if it occurs throughout the PSG, it should be mentioned in the narrative. Okay, let's talk about scoring of apneas in children. What is recommended? To score a respiratory event as an apnea, when all the following criteria are met: a drop in the peak signal excursion by greater or equal to 90% of the pre-event baseline using an oral nasal thermal sensor, PAP device flow, or an alternative apnea sensor. The duration of the greater than or equal to 90% drop in sensor signal lasts at least the minimum duration as specified by obstructive, mixed, or central apnea duration criteria, or the event meets respiratory criteria for obstructive, central, or mixed apnea. To score an apnea as obstructive, if it meets the apnea criteria for at least the duration of 2 breaths during baseline breathing and is associated with the presence of respiratory effort throughout the entire period of the absence of airflow. Score an apnea as central if it meets the apnea criteria and is associated with absent inspiratory effort throughout the entire duration of the event, and at least one of the following are met. The event lasts greater than 20 seconds. The event lasts the duration of 2 breaths during baseline breathing and is associated with an arousal or greater than 3% arterial oxygen desaturation. The event lasts at least the duration of 2 breaths during baseline breathing and is associated with a decrease in heart rate of less than 50 beats per minute or for at least 5 seconds, or less than 60 beats per minute for at least 15 seconds. To score an apnea as mixed, it meets the apnea criteria for at least the duration of 2 breaths during the baseline breathing and is associated with absent respiratory effort during one portion of that event and the presence of inspiratory effort on another portion, regardless of which portion comes first. Okay, getting down to the end of it, the scoring of hypopneas are the same as in adults for children, and the scoring of Cheyne-Stokes breathing are the same as adults for children. Okay, we've come to the end of section 6, unit 6. Our 8 objectives have been covered. Please email me if you have specific questions on any of the material. I hope that this has been beneficial and you understand some of the respiratory monitoring. So have a good week. I'll talk to you next week. Thanks.